Hey everyone, I'm your host Adrian. We do content like this weekly, so hit the subscribe button and ring the bell to get notified. If you want more content like this, click the like button and please leave a comment. Thanks again for watching. Welcome everyone to today's Rupa Live class presented by Rupa University, the best way to learn about specialty lab works from industry experts. My name is Adrian Martinez and I will be your host for this afternoon. Today we have a very, very special guest and Dr. Pamela Smith here with ZRT Laboratory, here to walk us through how to maximize your male hormones. Before jumping in, a couple of quick housekeeping items. Everyone joining will be muted by default, but if you have any questions, please use that Q&A button down in the menu bar and we'll host a live Q&A session at the end of the presentation. Immediately following Q&A, yours truly will show you exactly how to order these tests on Rupa Health. And if you have to jump early, no worries at all. We are recording this session and you'll be able to find it on rupauniversity.com, as well as we will disperse the recording along with the slides in the coming days. And if you are a fan of this type of content, be sure to check out rupauniversity.com to get access to all the previous sessions that we have done, including those with Dr. Smith. And finally, Dr. Smith and ZRT have been gracious enough to offer up to 100 copies of her new book to today's attendees. So be sure to stick around and we will send out the winners within the coming days here. But with that, let's go ahead and jump in. I'd like to introduce Dr. Pamela Smith. Dr. Smith spent her first 20 years of practice as an emergency room physician with the Detroit Medical Center in a level 1 trauma center, and then 28 years as an anti-aging functional medicine specialist. She is a diplomat on the board of American Academy of Anti-Aging Physicians and is an internationally known speaker and author on the subject of anti-aging precision medicine. She holds a master's degree in public health, along with a master's degree in metabolic and nutritional medicine. Dr. Smith is in private practice and is the senior partner for the Center for Precision Medicine, with offices in both Michigan and Florida. She has been featured on CNN, PBS, and many other television networks, has been interviewed in numerous consumer magazines, and has hosted 2 of her own radio shows. Dr. Smith is the founder of the Fellowship in Anti-Aging, Regenerative, and Functional Medicine, and is the past co-director of the Master's Program in Metabolic and Nutritional Medicine at the University of South Florida. She is the author of 11 best-selling books, including her most recent book, Maximize Your Male Hormones. Always great to see you, Dr. Smith. Thank you so much for joining us today. I will go ahead and let you take it from here.
Thank you so much, Adrian. Hello, everybody. I hope you are all doing well, whether you're joining us in the morning or the afternoon. Today, we're going to spend a little while looking at what you must know about male hormones. A lot of the references are on the slides. Some are in my book that was just released, Maximize Your Male Hormones. It's kind of my editor really thought, and my publisher, that men wouldn't read a book on hormones, but it's actually sold out twice already. So it's amazing. It is a time to look at male hormones. So what is actually the definition of what we call andropause or hypogonadism? It's an absolute or relative insufficiency of testosterone or its metabolites in relationship to the needs of that individual at that time in his life. So when it comes to hormone production, most people don't even know that are clinicians and how much testosterone does a male actually produce. Depending on the study, 4 to 6 milligrams a day, 4 to 8 milligrams a day. It's probably not as much as you think. His testosterone level does change throughout the day 4 to 6 times. What are the functions of testosterone in the body? Yes, it has to do with sexual interest, but it truly is so much more. There are receptors all over the male's body. So it does help prevent macular degeneration, cataracts, and glaucoma because there's receptors of testosterone in the eyes. There's receptors in the heart. There's receptors on the colon. They're in many locations beside the obvious ones. Testosterone is involved in the making of protein and muscle formation, helps manufacture bone, improves oxygen uptake throughout the body, helps control blood sugar. It's needed for normal sperm development, and it regulates acute HPA responses under dominance challenge. It does help regulate cholesterol. It helps maintain and the immune system, aids in mental concentration. In fact, honestly, testosterone for a male is his memory. It improves mood. I didn't put it on here, but I could even add it's his vocal cords. So if you're going to a concert and you want to hear somebody that was really popular 30 years ago, make sure he's on testosterone, because the vocal cords will be nice and strong if he is. Testosterone helps protect the brain against Alzheimer's, and it regulates the population of thromboxanthine A2 receptors on the megakaryocytes and platelets, and therefore platelet aggregation. So just a lot of references there for you. Signs and symptoms of andropause and late onset hypogonadism: fatigue, tiredness, and loss of energy. Depression, lower negative mood, irritability, anger, bad temper, anxiety, and nervousness. Concentration is not as good, neither is the sex drive or libido, loss of erections or problems during intercourse, decreased intensity of orgasms, weight gain, even back pain, joint pain, and stiffness can be a symptom of andropause. Loss of fitness or the ability to build muscle mass, feeling overstressed, a decrease in job performance, a decline in physical abilities, bone loss. Yes, men do get osteopenia and osteoporosis. Elevated cholesterol. There is an increased risk in heart disease. There's an increased risk of insulin resistance and diabetes as well. So looking here at the medical literature, trials showed men with coronary artery disease had a significantly lower total testosterone, free testosterone, and bioavailable testosterone. So let's really march through the medical literature and see what happens when testosterone is on decline. Studies reveal low endogenous testosterone concentrations are related to mortality due to cardiovascular disease, but other causes as well. Studies showed a possible correlation between low T, erectile dysfunction, and conditions associated with higher cardiovascular risk from the very conservative Journal of American College of Cardiology. This study revealed that men with CHD that were under the age of 45 had total and free testosterone levels significantly lower than controls. If you're interested in hearing a great deal about what happens with patients 40 and under from an anti-aging approach, then please come join us in Orlando at the Spring Anti-Aging Conference. I will be speaking on testosterone and how you raise it in men under the age of 40, because that is becoming a growing issue. When I first started doing this kind of medicine 30 years ago, it was very rare I saw a man under the age of 45 with low testosterone. It is becoming now quite common. Serum free testosterone levels were found to be inversely related to carotid intima media thickness and plaque score. Low T was found to be associated with arteriosclerosis from the Journal of Internal Medicine. And here, low testosterone associated with increased risk for the development of type 2 diabetes and metabolic syndrome. Lots of references on this. Since testosterone has been shown to lower blood sugar, the Endocrine Society now recommends measurement of testosterone in all males with type 2 diabetes. In fact, the Endocrine Society is now suggesting that the #1 treatment for diabetes in a male with low testosterone is to give him testosterone if he is a candidate for it. This study showed that low testosterone predicts mortality, again from cardiovascular disease. Here, low testosterone associated with an increased risk of all-cause mortality, independent of numerous risk factors. They looked at serum testosterone inversely related to mortality due to not just heart disease, but even all cancers. Here, low endogenous testosterone associated with an increased risk of death from all causes and cardiovascular disease. In men, testosterone levels do begin to decline around the age of 40 from the study from 2017. But again, now we're seeing it in 20s and 30s. This decrease has been associated with an increase in all-cause mortality and cardiovascular risk. The severity of coronary disorders was more adverse in men with suboptimal levels of total testosterone. This is from the Asian Journal of Andrology. So we're seeing this worldwide. The incidence of coronary arteriosclerosis, coronary calcium score, peripheral artery disorders, aortic calcification were found inversely correlated with suboptimal levels of total or bioavailable testosterone. How about hypertension? Studies showed that low total testosterone concentrations are predictive of hypertension, suggesting total testosterone as a potential biomarker for increased cardiovascular risk. Same thing with heart failure. In males with heart failure, low serum androgens were associated with an adverse prognosis. In men with chronic heart failure, anabolic hormone depletion is common, and deficiency of each anabolic hormone is an independent marker of poor prognosis. I think you're getting the hint here, right? That testosterone is very important for men. This animal study suggests that it's important for memory. Here, in a study that is a non-animal study, subclinical androgen deficiency suggested to increase the expression of amyloid plaquing, both in vivo and in vitro. In this study, age-related decline and free testosterone predicted age-related decline in visual and verbal memory, and low levels of bioavailable testosterone, positive predictor of memory loss in men as they age. A medical trial done in Hong Kong, men with low bioavailable testosterone, strong correlation with memory, Alzheimer's disease, males that have a higher ratio of total testosterone to sex hormone binding globulin have a lower rate of development of Alzheimer's. Still looking at memory, patients with Alzheimer's have been shown to have lower ratios of total testosterone to SHBG compared to age-matched controls. Another study, we could do this all day long. Prospective longitudinal study revealed the risk of Alzheimer's was decreased by 26% for each 10-unit increase in free testosterone at 2, 5, and 10 years before the diagnosis of Alzheimer's was made. Low testosterone has been associated with mild memory loss that's not related to Alzheimer's, and studies have shown a correlation between testosterone and cognitive abilities, such as spatial performance and mathematical reasoning. An animal trial showed the same thing. Another animal trial, both testosterone and dihydrotestosterone have effect on the upregulation of the hippocampal neurogenesis in adult male rats. Higher levels of free concentrations have been associated with better memory and cognitive performance. It doesn't matter the education of the patient, whether they're 35, 90, whether they've had cardiovascular morbidity or not. All of these things are associated with what happens with low testosterone. When we look at the total aspect, though, it doesn't give us as much information. And that's the reason why we always want to do the bioavailable form. So I always order my hormones by saliva testing. The reason I do that is severalfold. Number one, when you look at saliva testing, you get the bioavailable or free hormone, the amount available for the body to use. But studies have shown that if you put the hormones on the skin, and I'm going to show you some studies as to why we want to put the testosterone on the skin as opposed to IM or a pellet. When you put the hormones on the skin, it does not show up in the serum. That study was done by Dr. David Zava in 2017. An Israeli study was done, and we will publish this year our own trial funded by our own practice, showing that honestly, it doesn't matter the hormone, it doesn't matter the age of the patient, male or female. If the hormones are put on the skin, they do not show up in the serum. So therefore, if you use serum testing, you will overdose every single patient. So I do suggest to you start with saliva testing so that you can compare apples to apples and continue saliva testing. What we do is we measure and then we repeat the testosterone level by saliva in 90 days and every 6 months thereafter. And men that have undergone hormonal treatments for prostate cancer with suppression of endogenous testosterone synthesis and blockade of the androgen receptor, you know what you're going to find. There's a decrease in verbal memory. It did negatively impact spatial performance. Another study, patients with prostate cancer, plasma amyloid plaquing was elevated as testosterone levels declined. In this study, when testosterone for prostate cancer was discontinued, the memory improved, but the visuospatial abilities did not. So now that we've marched through the medical literature and that we understand that testosterone has so many functions in the body, let's look at what happens with replacement and balance of the hormones. And then how do you actually balance them? What do you do on Monday morning? So lab work, you do need to do. We talked about salivary testing to measure the hormones. Dihydrotestosterone, right on the saliva test is the estradiol and estrone. You do need to get both of those estrogens. Saliva test has DHEA. You do need to get a complete blood count. It's actually malpractice not to look at an H&H. You've got to look at the hemoglobin and hematocrit. Have to look at cortisol. There's six clinical trials showing that cortisol has to be measured by saliva. It's no longer in anybody's realm, even if you don't do this kind of medicine, for it to be done by blood. Of course, we want to look at sex hormone binding globulin and look at progesterone by saliva as well. PSA, you may, if the PSA has been borderline, want to look at free PSA as well. You do need to look at albumin because some of the hormones are carried on albumin, FSH, LH, and of course the traditional lab work, which I lovingly call an SMA, an old term, but basically blood sugar and looks at electrolytes, kidney and liver function, etc. A digital rectal exam should be performed every 6 months if the patient is on testosterone replacement therapy. A PSA of less than 4, but rising by 1.5 in 1 year or 0.75 per year over 2 years does need further evaluation. Old school thinking to say if it's under 4, it's fine. In other words, if the PSA doubles in a year, off to urology the patient goes. And of course, if the PSA is above 4, they do need to have a urological evaluation. We do want to look at estrogens. Men do make 3, estrone, estradiol, and estriol. It is important to measure at least E1 and E2. E3 is experimental. The only time I actually write a prescription for estrogen in males is for E3. There's great studies on multiple sclerosis that E3 is a treatment for both men and women, one of the treatments for MS. Males do need a small amount of estrogen to maintain memory and bone structure, so you don't want their estrogen to be low. You want it to be dead center of normal. Androgens aromatize into estrogens via the enzyme aromatase. And early studies show the E2 binding in numerous male tissues, so they have an estrogen receptor 1 and 2, show unique distributions and actions in males. Exogenous estrogen treatment produced male reproductive pathologies in lab animals, and men during development and studies with mice. Compromised estrogen signaling demonstrated an E2 role in normal male physiology. So when we look at the epididymis, all of these, the signaling is dependent on estrogen receptor signaling. So estrogen's main receptor is essential, that's receptor 1, for male fertility, the development of efferent ductiles, the epididymis, and prostate. Loss of the only membrane fraction of the estrogen receptor 1 was sufficient to induce extensive male reproductive abnormalities and infertility. So in other words, men make estrogen, Do they need estrogen? They absolutely do. However, too much estrogen does increase their risk of heart disease and prostate cancer. And as men age, estrogens go up. So it's important to look at estrogen at every age group. Loss of the ESR1 or aromatase also produces effect on non-reproductive targets like the brain, adipose, skeletal muscle, bone, cardiovascular, and the immune system. So there's also a suggested role for E2 signaling as well. So if the patient is aromatizing too much, what do? A lot of these things work. Actually, they all do. My personal favorite is chrysin. It's compounded. It can be given PO or transdermally. However, I always give it on the skin. It just gets absorbed so easily, no side effects whatsoever. And honestly, so far in 30 years that I've been doing this kind of medicine, it's worked in every single patient. You can also use zinc, flaxseed, EGCG. Early on, we used anastrozole or a related medication. Having used anastrozole, I was looking the other day, I think for 15 or 16 years, because chrysin works so well. Ways to increase aromatization if you need to, or things that increase aromatization, I should say, inflammation does. So if you decrease the inflammatory component, it does help with aromatization. Obesity, high insulin levels, too much alcohol intake, toxic mold syndrome, and chronic inflammatory response. All of these things are ways or reasons that the patient aromatizes too much. So you want to decrease all of these. Estradiol has a protective effect on the brain structures in older males. And here, serum estradiol and testosterone levels have been shown to be lower in men with Alzheimer's disease compared with age-matched controls. Medications can lower estrogen in men, so be aware of that. Sometimes you see too low of estrogen on the saliva test. These medications are commonly one of the culprits. It is experimental at this time, but again, here's your reference on multiple sclerosis. Estrogen levels may elevate as men age for all these reasons: an increase in aromatase, alteration in liver function, zinc deficiency, obesity, overuse of alcohol, ingestion of estrogen-containing foods or environmental estrogens like phthalates. Too much testosterone is actually the #1 reason now why we have aromatization occurring. When you give too much, when you prescribe too much for testosterone in men, it does not stay testosterone. It converts into DHT, E1, and E2. So giving too much actually is not beneficial. It does harm the patient. There is an increased risk in heart disease and an increased risk in prostate cancer. And even though testosterone lowers blood sugar, if you give too much, the blood sugar may climb. I never prescribe more than 50 milligrams of testosterone transdermally. There's just not a need to. If you look at the dose response curve, that it gets absorbed very well. You might say today, when you're listening, I can't get the testosterone to absorb on the skin. What do I do? Well, you would put it in a special base. There is a base particularly made for testosterone, and that is called Atrevis, ATREVIS. I usually put my hormones in Versa base, VERSA base. But if I can't get testosterone in, there is a special base for both men and women for testosterone, again, Atrevis, ATREVIS. Other ways estrogen levels may elevate: environmental estrogens, endocrine disruptors. There are foods that can increase estrogen. If you don't have a list of those, you can email me at faafm63@yahoo.com. That's faafm63@yahoo.com, or you can contact ZRT Laboratory or Rupa They will all have a copy. We want you to have foods that increase estrogen, so you can take people off those foods if their estrogen is high, and then medications. Elevated levels of estrogen in men are associated with gynecomastia, decreased sex drive, and erectile dysfunction. There's double the risk of stroke, higher rates of heart attack, PAD, coronary arteriosclerosis, insulin resistance, rheumatoid arthritis, BPH, and prostate cancer. The study showed that high estradiol in males increase risk of stroke, here an increased risk of myocardial infarction, and here promoted the development of a poor lipid milieu. Low testosterone and elevated estradiol was associated in this study with lower extremity PAD in older men. There's another one on high estradiol, low testosterone associated with acute MI. Same thing here as well. Same thing here as well. So if the estrogen is high, again, if the patient's on testosterone, try lowering the dose. You may have overdosed the patient. But if you're doing saliva testing, you're going to see that when you get the result. Zinc, chrysin, as we mentioned, anastrozole. Other things, grape seed extract, wild nettle root can also be very helpful. A decrease in estrogen-containing foods, and eat foods that decrease estrogen. There's actually foods that decrease estrogen. Again, email me, contact ZRT, etc. We can get you those lists if you don't know what they are. Other ways, Mucut will help, decreasing alcohol intake, losing weight if the patient's obese, estrogen is stored in fat cells, eat organic foods, avoid environmental estrogens. High dose vitamin C increases testosterone production, vitamin K, niacin. So in other words, one of these will work in every single patient. So what happens when you give testosterone? Here, erectile dysfunction affects 1 in 5 men. Prevalence of comorbidities as well. Testosterone is helpful. The available literature supports a role for testosterone replacement in men with low T, ED, low libido, with symptomatic improvement in these men. Restoring testosterone levels to normal in men with proven subnormal testosterone improves libido in most subjects and erectile dysfunction in more than 50% of these men. They took it for 14 to 25 weeks. It took that long for testosterone to become manifest. Testosterone replacement here improved cognitive function. Here it prevented beta amyloid plaquing. Here it reversed cognitive dysfunction. So great studies on testosterone helping with memory. It helps with mild cognitive impairment, decreases beta amyloid plaquing. Testosterone therapy in older hypogonadal men improves spatial cognition and verbal fluidity. Here it helped with memory errors. Here helped with early Alzheimer's, helped with global cognitive function, neuroprotective. Here, the study revealed promising associations found between cognition, testosterone supplementation in both eugonadal men. In other words, if the testosterone is low normal, would they benefit from a baby dose of testosterone? They might. Even though it's in the normal range, low normal, would I prescribe testosterone 5 milligrams transdermally? Commonly I do. Men with low T and with and without baseline cognitive dysfunction. Does it help with coronary artery disease? It does. This goes back to 1999 in circulation. It has a direct coronary relaxing effect. This study showed that testosterone decreased HDL-C and lipoprotein A. As you all know, lowering lipoprotein A sometimes is hard to do. The mechanism of testosterone replacement decreasing lipids may be due to its positive effects on abdominal fat and insulin resistance. Here, short-term administration induces a beneficial effect on exercise-induced myocardial ischemia. Same thing in the study, it increased coronary blood flow. low-dose supplementation with testosterone in men with chronic stable angina, reduced exercise-induced myocardial ischemia. This is from the very conservative circulation. Here, testosterone replacement increased coronary blood flow, helped with stable angina, helped with exercise-induced myocardial ischemia. There was a vasodilator. Again, we could go on and on. This one is very interesting from the Journal of American College of Cardiology. Testosterone replacement has been shown to decrease inflammation and lower total cholesterol. Almost every single disease that the patient will get after the age of 42 is honestly inflammatory in nature. Testosterone replacement can suppress the levels of circulating pro-inflammatory cytokines, stimulate the production of interleukin-10, which has an anti-inflammatory effect. Mortality, re-rated cardiovascular disease, significantly reduced in this group of people that received testosterone replacement. Reduction in mortality for the testosterone group was 66% and 92%. There were also 30 non-fatal strokes, 26 non-fatal myocardial infarctions in the control group. But in the testosterone group, nothing. They had no strokes, no myocardial infarctions. Studies have reported a reduction in cardiovascular risk as well. It improves myocardial ischemia. Here's a study on supraphysiological doses of testosterone from 2020. It does increase the risk of heart disease. So the TRAVERSE trial, begun was in 2018, was designed to evaluate this. Start low and go slow. So there's two things from today that you want to look at in prescribing. It's start low and go slow, and it's all about balance. The other thing that's very important to look at today is how to measure hormones. It's key to look at saliva testing. Testosterone replacement was shown to be effective in chronic heart failure. Here, another study on chronic heart failure, they had improvements in VO2 max. Another randomized controlled trial conducted on patients with CHF, testosterone over 3 months, resulted in a significant improvement in diastolic function and the ability to walk. Here, an improvement in exercise capacity. Another study on inflammation, testosterone replacement in men with cardiovascular disease decreased TNF-alpha, a major inflammatory marker. Interesting from Mayo Clinic proceedings, there's no clinical evidence that the risk of either prostate cancer or BPH increases with transdermal testosterone replacement. Because people still ask me, do I have to worry about getting prostate cancer? Is my prostate going to be enlarged? The answer is no, appropriately prescribed. Men that are older with the highest risk of prostate cancer, interestingly, do have the lowest levels of testosterone. When it comes to diabetes, which is probably the disease process that honestly will cause patients the long-term issues, it's also the most costly disease to treat. People think it's cancer, it's not, it's diabetes. Several studies have shown that in the presence of significant insulin resistance, testosterone replacement increases insulin sensitivity. It improved blood sugar levels in patients with type 2 diabetes. This is evident after 3 months. It does take 3 months for testosterone to work, and it was maintained for the length of the study, which was 1 year. These studies showed the exact same thing. So testosterone replacement decreases insulin resistance. However, supraphysiological doses increases insulin resistance. Hyperinsulinemia, testosterone decreases. You give too much, insulin goes up. This study suggests that testosterone replacement therapy should be considered as one of the treatment options to improve hypogonadal symptoms and bone mineral density. That was a trial that just came out in 2021. So when we look at testosterone replacement therapy, And I realize as questions build up in the Q&A, and I promise I will take these questions. There will be additional training. There's going to be a new course that's going to be offered with a major medical school in looking at personalized health. And of course, the first course is going to be on hormones. If you're interested in that, contact myself, contact ZRT or Rupa. Testosterone replacement for men, it's safe and it can provide significant benefits. Studies have been going on that are controlled and uncontrolled for 70 years. There's not a reported age at which hormone replacement in men over the age of 50 should not be considered. So a cream or a gel, studies have shown that transdermal testosterone is physiologic, efficacious. It has a good safety profile. IM, testosterone, and sub-Q are possible modes of administration. However, they produce highs and lows. So it used to be if we gave IM testosterone, we gave it every other week. Then we went to twice a week, like Mondays and Thursdays. But what happens is the day after you give IM testosterone, the level's too high. The next day, the level is great, and the third day, it's too low. So you do get these high and lows if you use IM or sub-Q. Acne and polycythemia are less common with this form of therapy with the intramuscular esters. So transdermally applied, honestly, has become the preferred method. Transference is an issue. So there are FDA warnings. How long does it take for transference? Up to 12 hours. So accidental transference can lead to virilization. It can be transferred to not just children, grandchildren, but cats and dogs. So to prevent this, apply it to the areas where clothing will be put on. So we usually suggest the inner thigh or the top of the foot. A lot of that also has to do with the fact that that's where men have less hair. The more hair, the harder it is to absorb. So inner thigh or top of the foot. Hands should be thoroughly washed with soap and water after application. The skin-to-skin contact is anticipated. The area should be washed thoroughly before contact, and swimming and bathing should be avoided for at least 2 hours after application. These are common questions that people have asked us. Transdermal, we'd love to have it compounded by the compounding pharmacy so we can titrate the dose as a customized and individualized, personalized medicine approach for the patient. Great study here. People say, well, does it really have to be transdermal? Well, this study looks at erectile dysfunction. Transdermal, 81% effective against ED. Orally, 51%, IM 53% of the time. So much more effective for erectile dysfunction from the Journal of Urology if you put it on the skin. So dose is usually 5 to 50 milligrams as a cream or gel, depending on the base. If the patient has high estrogen, then you can put Chrysin right in that same syringe or pump. Chrysin does have a natural yellow color. It doesn't stain the clothes, but usually the patient the first time is kind of shocked that it's yellow. That's why it's yellow if you have put Chrysin in there. Also, men do need progesterone. Progesterone is very important for nerve endings. Right on the saliva test is the progesterone level as well. It's also important for memory. In the same syringe, you can put testosterone, Chrysin, and you can put progesterone. In the same syringe or pump, can you just give Chrysin only or progesterone only? Absolutely, positively. So when it comes to formulations, shoulders, abdomen, and upper arm is what is suggested by the FDA. We do find, again, that the inner thigh or top of foot works very well. Testosterone gel made by a drug company. Here are the listed side effects: acne, headaches, emotional lability, nervousness, gynecomastia, acidemia, insomnia, hypertension, hot flashes, polycythemia, and an increased PSA. But again, a lot of those are really related to too much testosterone and conversion into other hormones. So testosterone here There's patches, there's tablets. I included for everybody the different varieties of testosterone injection, so that basically you are aware of them. Do not instruct the patient to use sub-Q testosterone if it's an IM testosterone. Testosterones come as both IM and sub-Q. If it says sub-Q, then sub-Q is fine. If it says IM, the patient gives it sub-Q by your instruction and they get an abscess, then that's a problem for the patient and you. But again, I do suggest transdermally. So I put this all together in a nice little graph for you. So there's topical solutions. Individuals treated with testosterone replacement should be monitored, again, 3 months and then every 6 months thereafter. If the hematocrit rises above 54, the treatment should be stopped, underlined stopped, not cut down. But the FDA and the Board of Medicine in every state and province will say that when it hits 54, you must stop the testosterone. The patient at that point in time may very well need to donate a unit of blood so that the hematocrit will go down. When the hematocrit goes down to 45, then you can reinstitute the testosterone. The idea is not to overprescribe testosterone and have the patient donate a unit of blood every month. That is not the idea. The idea is you give the appropriate amount, 5 to 50 milligrams, to the patient every day. The patient should discontinue testosterone and see their urologist if the PSA increase in 6 months is doubled. If it's above 4, then at least they need a digital rectal exam as well. The clinical response to transdermal testosterone is variable. That's the reason why we go back and we remeasure. The lipid profile begins to improve in 3 to 4 months. It doesn't happen immediately. The patient will say to me, "Oh, will you please measure my cholesterol and see if it went down?" 3 to 4 months. Maximum effect in 12 months for total cholesterol and 22 months for triglycerides, high-density lipoprotein, and low-density lipoprotein. A decline in fasting blood sugar and hemoglobin A1C may take 3 months to see the initial, but the further effect does take 1 year as well. The effects of testosterone on bone density take longer. It may take 6 months to see the initial effect. It can honestly take up to 3 years to see the maximum effect when it comes to rebuilding bone. Patients with metabolic syndrome experience a benefit in waist circumference, fasting blood glucose, and blood pressure within 12 months. Again, it's important to set the right expectations with the patients so that they don't think, oh, in 1 week, everything is going to be improved. Improvement in sexual desire and function, as well as mood and energy, fortunately, usually occurs early in the course of treatment in about 3 to 6 weeks. Counterindications to the use of testosterone. Prostate cancer. Let's talk about that for a second. When men get prostate cancer younger, it tends to be a much more aggressive disease process. My favorite author, Vince Flynn, died at the age of 47 from prostate cancer. He had an aggressive form. Men who have prostate cancer young probably will never, ever, ever get hormone replacement therapy. That's not true of men as they age. From Morgenthaler's work and others, Morgenthaler was at Harvard, he recently retired. From his work and other people, if the patient is 65 or older or 70 and older, they have the non-aggressive form. If they have no reoccurrence in 2 years, you can consider testosterone. Obviously, if they've had a definitive treatment where the prostate's taken out and it was all contained in the prostate with no mets, then you can absolutely consider it. Again, this is with no reoccurrence. When it comes to older men, 5% is aggressive. So if it's an aggressive form, and the urologist will be able to tell you that, no testosterone. And older men, you can consider it if they have been cancer-free for 2 years. And that does vary from patient to patient. breast cancer is probably a lifelong counterindication. It used to be that 1% of breast cancer was in males. That has now changed. It's 3%. Prolactinoma, until it's removed, is a counterindication. Prostate nodules or indurations until they're investigated. Uncontrolled or poorly controlled heart failure. Until the patient is treated, even though testosterone helps, they need to be treated conventionally for heart failure. Then you can consider testosterone. Obviously, hematocrit greater than 50, you don't start testosterone to begin with. We talked about PSA. You do want to measure a free PSA if the PSA is elevated. The lower the free PSA, the worse the prognosis. Severe PH, severe untreated sleep apnea. If the patient has sleep apnea, please do not give them testosterone until it's treated. Severe liver disease and severe kidney disease. So far, I've not had a patient that liver and kidney disease was so great that I could not give testosterone if they were a candidate for it. Stimulating endogenous production. 2001 to 2011, men on testosterone replacement increased threefold overall, 4 times more among men and ages. So there has been a change. The best way in the world in younger men, the best way in the world in a younger male to fix his testosterone is to exercise. So testosterone replacement really should not be considered in younger males. Again, I'm going to speak shortly more on this, but I wanted to give you an idea. Have them exercise. You can give clomiphene citrate. It is a selective estrogen receptor modulator. It is not FDA approved, so some places where you live may not allow it. Most places do. As you know, 1/2 of the medications prescribed in the United States are off-label, so not FDA approved. Clomiphene would fall under that. It does not work in men over the age of 55. It does not work if the patient has a chronic illness either. And clomiphene does increase gonadotropins by inhibiting negative feedback on the hypothalamus. So it does increase LH and FSH. Studies have shown the clomiphene citrate for hypogonadism was safe and effective in patients wishing to preserve fertility. And here, low-dose clomiphene, 25 milligrams, was effective for hypogonadal males. And this study showed that clomiphene citrate and testosterone together gave good results. In this study, they were trying to maintain fertility. If you give testosterone by itself in younger men, then commonly they become infertile. Another study showed that clomiphene citrate was safe and effective as a treatment for hypogonadism. And here, medical trial using clomiphene 25 a day, then increased to 50, was successful from the British Journal of Urology International. Possible side effects of clomiphene: gynecomastia, Ludwig cell tumor or testicle tumor, pulmonary embolus. There's also HCG. Not every state and province allows for HCG. Many places do, however. It is a luteinizing hormone in the male produced by the anterior pituitary in response to pulsatile secretion of gonadotropin releasing hormone from the hypothalamus. And it does act on the Ludwig cells in the testicles. It promotes the production of testosterone. And men with hypogonadotropic hypogonadism, or men with decreased LH secondary to exogenous testosterone, the lack of LH results in severely decreased intratesticular testosterone levels. So without intratesticular testosterone, spermatogenesis is impaired. By replacing lost LH production with HCG, spermatogenesis can be restored by restoring adequate levels of intratesticular testosterone. It is a hormone with both alpha and beta subunits. In younger males, it is the preferred treatment to help maintain fertility. Testosterone, again, should not be used unless there is Ludwig cell failure. Now, you may say, oh, it doesn't really matter. That's actually not true. I had a patient who came to see me and he wanted testosterone. He was only 42. And I said, look, you need to wait till you're 45. He said, I'm done having kids. And I said, well, you never know. And he left my practice and he went to another practitioner. They gave him testosterone. And 5 years later, the patient was back in my practice. He wanted to have kids. His wife and 2 children were all killed in a train car accident. He was lucky enough to find another love of his life. Most of us are only lucky enough to find one, but he found 2, and she wouldn't marry him unless he could initiate a pregnancy. Unfortunately, we were not successful because he had used testosterone at too young of an age. So when we look at clomiphene and HCG, with HCG, if LH is greater, then HCG does not cause loss of testicular volume, and no decrease in sperm count may occur with testosterone replacement. HCG does need functioning Ledwig cells, though. So you measure the LH and FSH, okay? So when you look at LH levels, if it's 5, then HCG may not work. If it's less than 3, it's probably going to work. If it's between 3 and 5, then it's very variable. So you can have some idea of what will happen. This study found the treatment of hypogonadal symptoms with HCG for men have a baseline level of testosterone that was greater than 300, appears to be safe and efficacious with no major side effects. And these are guidelines that should be used when using HCG for low testosterone in men. So I put here how much to give. Antibodies can develop. So total free bioavailable testosterone usually increases about 25%. Possible side effects of HCG: pain, redness, swelling at the injection site, stomach pain, nausea, vomiting, anaphylaxis, gynecomastia. It can cause water retention and edema, deep vein thrombosis, pulmonary embolism, intracranial lesions, acne, and hypertension. You do need to make the patient aware. Counterindications to HCG: do not use if they have prostate cancer or other androgen-dependent neoplasms. Do not use orally. And some physicians use HCG with testosterone and steroid-induced hypogonadism. When people abuse anabolic steroids, HCG has been found to have a prominent role. This study was done to evaluate the effect of selective estrogen receptor modulators. Non-testosterone therapies were again efficacious in this trial as well. So ways to suppress estrogen are there. Again, on erythrocytosis, having erythrocytosis is associated with an increased risk of developing heart disease and thrombosis. So don't go down that route. Stop the testosterone. Here's a study that the medical board will be referring. Major study on the risk and benefits of testosterone. Baseline hematocrit should be checked at 3 months, every 6 months thereafter. And just a case report. This is actually my own patient, 59-year-old male who presented for a follow-up visit. I had already put him on testosterone. Didn't take much. He was only on 5 milligrams. He was feeling much better, but his wife had noticed that he was developing breast tissue. He was also on pregnenolone 30 milligrams. Nothing else was remarkable. Here is a copy of his saliva test. Unfortunately, and this does happen, he didn't close the saliva tube well, so part of it spilled on the way to the lab, and so we could not get an estrone. But you should always get an estrone, an estradiol. Here, his estradiol was high, progesterone was fine, testosterone was normal where he was at, DHEA was low normal, and there's his cortisol. It's a little bit high in the early evening. So you'll also on the test, you'll see symptoms. This is also extremely helpful to see what symptoms the patient's having. So what did we do with this patient? We basically, because he had the high estradiol, he was on the 5 milligrams of testosterone, we added a little bit of chrysin to that. So he became 5 milligrams testosterone with 3 milligrams of chrysin. We repeated his pregnenolone by blood, and that dose was perfect for the pregnenolone. The rest of his studies, PSA, CBC, etc., were unremarkable. In conclusion, maintaining optimal hormonal levels in men is an essential tool to aid the patient in achieving optimal health and actually preventing disease. It is the ultimate anti-aging therapy. It does matter if you dose right. An optimal way of dosing is to put it on the skin. It does matter if you measure the right things. When something is placed on the skin, any hormone, you do have to do saliva testing in order to actually get the right dose for the patient. Otherwise, you'll overdose. Thank you very much, and I'm happy to go ahead and look at some questions.
Dr. Smith, I think we got more or less a million questions that came in. So thank you so much for the presentation. Before jumping in, I know that we have this scheduled out an hour. We're likely going to go over, and Dr. Smith is gracious enough to lend some time to go over the allotted, but I know that some of you might have a hard stop. So if you have to jump, no worries. We, of course, are recording this, and we'll go ahead and distribute the recording in the coming days. That will include the Q&A. And so with that, let's go ahead and jump right in. I'm going to go chronologically, and we'll get through as many as we can. But if you have any, go ahead and drop it in the Q&A. First things first, I think a lot of the audience wants you to come back for a female testosterone class, so we'll have to go ahead and schedule that one as well. But jumping right in, what is the best time to check male hormones?
And the saliva test is designed that you measure the hormones in the morning, 1 hour after the patient gets out of bed. When you put the hormone on the skin, they put it on 24 hours ahead of time. So in other words, they spit into the tube, then put the testosterone afterwards.
Perfect. What are the theories, if any, for the increasing incidence of low T in under 40-year-olds?
That honestly, that is a whole hour seminar. So I'm serious, please come join us
Yes.
at the anti-aging conference, because I will be speaking for a whole hour on that subject.
Amazing. And Rupa Health will be there as well. So be sure to check out the A4M Spring Congress in Orlando coming up in the next couple months. Actually, it's coming up pretty quick.
It's in May, yes.
There we go. May, I believe the weekend of the 19th, if I'm not incorrect.
It
there.
is.
Perfect. Would you start a patient on testosterone with recent onset dementia who has no other attributable etiology via clinical history or labs, assuming he's a low T and in other suitable for such treatment? And
I'm sorry, can you say that again?
Yeah, so assuming that he's low T and is suitable for other treatment, would you start a patient on testosterone with recent onset dementia who has no other attributable etiology?
I would. And there are studies, obviously I could have gone on for hours today. There are studies to show that if someone has early dementia, it will stabilize the patient for a length of time. There are some studies showing that it may mildly reverse some of the dementias that's there, but really, would I go ahead and start the patient? I would.
Yeah, that's great. And that's so interesting. Saliva testing to monitor any particular time of day in relation to when the transdermal testosterone is applied.
It honestly doesn't matter, but it's a practical reason. We usually tell people to put it on in the morning. If they have intercourse in the morning, have intercourse and then put it on. But then usually people go to work or whatever else is happening. And then in the evening, they can cuddle again because they'll be 12 hours. So for a practical reason, we usually say the morning is best.
Perfect. Saliva and serum testing, which is preferable for injectable testosterone, HRT?
When it comes to all hormones, no matter how you give them, urine testing, it's great to look at the metabolization of hormones, the breakdown products, but please do not dose off of a metabolite. I don't think anybody today on this Zoom meeting would dose thyroid off of a metabolite of thyroid. When you get a urine, you're getting a metabolite. You're not getting the actual measure of the hormone. And how I break it down and you all break it down is entirely different for every person, depending on age and how healthy they are and sex and family history and genetics. So please do not dose off of urine. It's important to do urine testing to look at 2,4,16-hydroxyestrogen and the breakdown products of the rest of the hormones. But do not dose off of urine because you're actually not dosing off of the level of the hormone itself. It needs to be saliva.
Yeah, super interesting. How do you dose testosterone in a male with a history of prostate cancer after prostate cancer surgery?
Again, I think I covered that a little bit there. If the patient is younger and it's aggressive prostate cancer, then he can never have testosterone. In an older patient, if it's non-aggressive, then you would wait 2 years with no reoccurrence, and then you can consider testosterone.
How do you measure progesterone?
Progesterone is measured by saliva as well. It's right on the same test, so it's easy to do.
Yep, amazing. And I'll show you exactly how to order that test here in just a few minutes. Why do you think men are doing better on injectable versus topical cream? They can give, a patient topical cream, but it seems that they plateau.
Actually haven't seen that problem. Okay, I really don't think they do better on IM. And I have looked at 80,000 saliva tests in my career. Literally 80,000 of them, with people using IM, sub-Q, or even oral testosterone, transdermal testosterone, pellets. Hands down, you will get a better result by putting it on the skin. If the patient has a thicker skin, then again, just use that Atreva space and you'll find it's much better than the highs and lows that you get with IM testosterone.
Beautiful. What is the best way to measure hormones in a male undergoing infertility testing who is not taking hormones?
It still is actually to do saliva testing, because you want to see where his cortisol is. His cortisol can negatively impact his fertility. You want to be able to look at estrogen. And all of those hormones on saliva testing have an effect on what happens with fertility.
I love it. Do you suggest increasing phytoestrogens for men?
Again, the only time I've honestly prescribed estrogen itself is for MS. I haven't had anybody with encephalitis, so haven't tried it with that, but it is MS. Otherwise, if they have low estrogen, I want to find the cause. It's commonly a medication, or I may have them eat the foods that actually will raise estrogen in the body. So again, I'm happy to provide that list to you of the foods.
Perfect. So just to confirm, is there an increased risk in developing prostate cancer or just prostate hypertrophy in men with elevated estrogen?
I'm sorry, I didn't get that one.
Yeah, so just to confirm, is there an increased risk in developing prostate cancer or just prostate hypertrophy in men with elevated estrogen?
When men with elevated estrogen, if you leave it high, there is an increased risk in prostate cancer.
Okay, perfect. Testosterone replacement. Are there any holistic mechanisms to increase testosterone?
There are, and that seminar I'm giving on younger males are all the holistic ways to do it.
I love these plugs. Be sure to check out the Spring Congress A4M Orlando, May 19th. Be there and check it out. Does a 24-hour urine testing give accurate results similar to a saliva testing for hormones?
It does not. It's urine testing is just the breakdown. It is a metabolization products. It is not the measure of the hormone itself.
Perfect. In a metabolic syndrome male with low saliva testosterone, would you first work on a sugar metabolism and recheck T, or use topical T at the same time?
Because testosterone has so many positive effects, and that's a great question. Thank the person who asked it. I really do start testosterone right away if they're a candidate for it. At the next office visit, I have them come in a month, and then we start working on the other aspects of blood sugar. The patient does know that the effect they're going to get from testosterone won't be for 90 days, but most people, testosterone by itself is not enough. So when they come back in a month and we look at low glycemic index and exercise and nutrients like, chromium and alpha lipoic acid and berberine and bergamot and everything else.
Perfect. Would you prescribe testosterone replacement IM to someone with a strong family history of prostate cancer and moderately elevated PSA of greater than 4 but less than 10?
No.
Have you seen any correlation between low testosterone and incidence of obstructive sleep apnea?
Only, again, if they have sleep apnea, it should be treated first. It is a counterindication to not treat sleep apnea and give testosterone. And every medical board in the world, not just the United States, would tell you that. So sleep apnea must be treated first, then give testosterone.
Yeah, great. In past decades, we were told that transdermal testosterone increased hair loss, something I actually heard about as well. But now they're hearing that that's not the case. Is there evidence, and do you know of any evidence either way?
Honestly, I've never had, remember, I fixed the gut too. I mean, people always ask me, is it more important to fix the gut or is it more important to take hormones? The patient's not healthy until both happen. Okay. So my patient has a healthy gut. Okay. So I don't get as much of the hair loss situation. Plus, I don't overdose the testosterone. So it's not converting to DHT. Having said that, I've had no patients had hair loss ever in 30 years I've been doing this kind of medicine.
Good to know. So this one, next question, curious in regards to testosterone decreasing insulin resistance. So in women, we see that there is a cycle that occurs with insulin resistance and testosterone basically feeding each other. Is it simply a different mechanism in men? If so, any insight as to why there's such a difference between men and women? Thank you.
For both men and women, it's important to have testosterone at the right amount. Too much or too little can drive up blood sugar in both men and women because they will cause insulin resistance. Remember that when it comes to women, and the references are in my book, What You Must Know About Women's Hormones, second edition. When it comes to women, only 1/4 of women perimenopausally and menopausally have low testosterone. 1/2 of women have normal testosterone for the rest of their life. I'm one of those. It's dead center of normal. It always has been. I'll be 69 in a couple of months. It isn't going to change now. So of the remaining 1/2 of women, half of those or 1/4 of women will have high testosterone. So that only leaves 1/4 of women with low testosterone. Unfortunately, now this is the new addiction, is testosterone. And we're just giving testosterone to all these women, honestly, that do not need it. That's why we have to do saliva testing and we have to appropriately treat these patients. I have a patient who I was consulted on that was sent to me by a conventional cardiologist. And it was a woman, no family history of heart disease, high cholesterol, high blood sugar, or hypertension. At the age of 41, she'd had 3 acute MIs from her testosterone pellets that were way overdosed. They were a dose I would give a guy. It's sexual interest. The number one reason it decreases is actually stress. So it's not testosterone for men or women. It's actually that people have abnormal cortisol.
Mm-hmm. Yeah, super, super interesting. There's just like so much emphasis on the hormones, and then kind of like you mentioned before, there's external factors that need to be considered as well, right? A common question that we get is about HCG and sermorelin. Any comment on the use of sermorelin and HCG and any benefits that may have in men using TRT?
Would love to see more studies with the addition of the sermorelin. So I haven't seen a lot of those. If the person who asked that question has some, please forward them my way.
Yes, I love it. Can low testosterone be secondary to the use of topical tretinoin 0.05 for 3 months in a 25-year-old patient?
Yes.
Perfect. Excuse me, you might hear my dogs playing in the background, so sorry about that. How do you treat high estrogen in males? Anything else other than Chrysin?
Yes, all the things that we gave you. So we gave you a list of all those.
Yep.
Chrysin would certainly be the number one, and anastrozole would be the last one. So EG, CG, zinc, etc.
Perfect. Let's see. Does infertility from testosterone replacement reverse once the testosterone replacement is stopped?
Commonly not. That's why I told the story about the poor gentleman whose wife and 2 kids were killed in a train car accident. It commonly does not reverse.
Yeah, and we're going chronologically here, so I think you might have gave that exact story after this one. Let's go through here. I think you might have answered a number of these already. What do you use to try to recover T after using testosterone prescription?
I try, exercise is certainly number one.
Mm-hmm.
So I try do a detox and see if we can get some of the testosterone out of the body. But if it's gone on for too long, usually, honestly, it's not fixable if you're talking about fertility issues. So, I work with a lot of athletes. Some of them have abused androgens, and they are probably the hardest patients I have, are people who have overdosed on any hormone for any reason.
Yep. As a former athlete myself, I have a number of friends who are experiencing similar issues. To prevent testicular shrinkage with testosterone treatment, would you combine HCG and testosterone? And if yes, how would you correlate the dosage?
You probably will get some testicular shrinkage with testosterone, actually at any age.
Mm-hmm.
So that's probably going to happen anyway. Combining HCG with it in a younger male, that may prevent it. In a male over 50, it probably isn't going to prevent it. And there's probably not a lot of advantage of doing that.
Yeah. What are the urinary metabolites useful for in treatment plans?
Oh gosh, that's a whole hour and a half talk in itself. His urinary metabolites. Oh. So come look at the certification I was talking about. We will actually have a professor speaking on urinary metabolites and talking about all that. That's a whole nother hour and a half discussion.
I think we just need to hire you as a permanent instructor here, Pam. I think that's the way to go about it. Speaking of some of the lectures, we had just a question coming through the chat. Do you know if the lectures at A4M are going to be virtual as well?
Do I know if what?
If the lectures that you'll be giving will be virtual for A4M. Do you know if the A4M Spring Congress will be virtual as well?
You can contact your A4M representative and they can answer that question for you.
Yeah, that's a better answer there. Can chronic nocturnal hyperhidrosis caused by reduction in testosterone in older males be caused by, assuming?
I'm sorry, I missed the first part.
Yeah, can chronic nocturnal hyperhidrosis be caused by reduction in testosterone in older males?
Don't know the answer to that one. It's rare that, because I do hormones are kind of my thing. I do not know the answer to that. So that one I'm going to review myself. Great question.
Yeah, perfect. So we have so many other questions coming in. I'm going to go through one more question. Let's find it here, and then we can go ahead and wrap it up, and I'll jump into a demonstration of Rupa Health. And again, we are recording this session, and we will go ahead and distribute it out next week once our team has the chance to go ahead and do some edits to it. What would be your preferred way to treat a high-functioning autistic spectrum, young, mildly obese, in their 20s who has symptoms of low testosterone, on saliva testing, has a slightly elevated estradiol and low for age testosterone?
My favorite way would be to, number one, help them with an exercise program. Number two, I would start them on chrysin or something similar to lower the estrogen. Let's work on weight and then see what happens. A lot of times just having people normalize their weight is very effective. Weight loss is not easy. I'm not suggesting it is. It can be very difficult for the patient, but encouragement, I think, is the biggest thing that people need for weight loss.
Yeah, absolutely. Dr. Smith, always such a pleasure to have you here. Do you have any final thoughts for the attendees that are sticking with us?
Absolutely. Again, thank you all for attending today, truly. If any of you are wondering, do I use Rupa? I do actually use it in my personal practice. I don't speak for anybody that I don't use. And do I use ZRT for saliva testing in my practice? Yes, I do use ZRT and have for many years. So for those of you who are wondering, do I use both of these companies? I do.
You're so sweet. Thank you so much, Dr. Smith. I'm excited to see you in the upcoming conferences. Be sure to check out Dr. Smith's upcoming presentation at A4M in Orlando, May 19th. We appreciate you having us or joining us every single time. It's always a pleasure. And be sure to check out ZRT. So what I'm going to do real quick, and Dr. Smith, you're welcome to stick around, but I'm going to do a transition over to Rupa Health and show you exactly how to order these tests from our platform. As Dr. Smith mentioned, she uses Rupa Health, and so should you. And so before jumping into any of that, I'm going to do a quick introduction of myself and Rupa Health. In case you don't know who I am, I'm Adrian Martinez. I'm the head of practitioner partnerships here at Rupa. And really what that means is that it's my job not only to just host these amazing webinars, but to answer questions and ensure practitioners are set up for success when thinking about using our platform or even actively using our platform. So what is Rupa Health? We are a functional medicine lab marketplace. So what we've done is we've designed a platform that's designed to make it easier for you as a practitioner, your clinic, your staff, to order all your tests in one place. We work with over 30 different labs, of course, including ZRT and a handful of others, and over 3,000 different tests. So now you have a one-stop shop to order all your tests. Now, beyond just a marketplace to order all your tests in one place, we also do these types of webinars. So Rupa University is the educational leg of Rupa Health, where we're not only hosting webinars with our amazing partners like ZRT and Dr. Smith on a weekly basis, we also create a magazine, we have a podcast, we have a ton of different resources available for you. So not only are you having access to all your tests in one place, but you have access to be able to learn about all the tests that we offer in one place. I'm going to navigate, and you can see my screen just over to the Learn About Lab section on Rupa Health. And what this is going to show you is basically an overview of kind of what our product is, right? So up at the top, and I'll zoom in, you can see all the different boot camps we offer. So beyond just free live classes, we offer 6-week more in-depth boot camps. This is a paid option. We have these live classes. So as you can see, we're on the one right now with Dr. Smith, but we have some upcoming as well with some amazing partners. We have all the lab companies. So like I mentioned before, we have over 30 different labs on our platform. So if you're interested in just hopping in and browsing by lab, you can even search by lab. You can browse by category. You can see some of our popular tests. You can even compare tests. Understanding that, whether you've been in functional medicine practice for 30 years or, 3 months, it can be a bit overwhelming knowing where to start. And so we want to provide you the tools to be able to get access to that information. So if you want to compare hormone tests on our platform, one click and you get access to seeing all the raw information from the different tests that we offer. Below that, you have access to all the recordings, including the ones that we've done with Dr. Smith, the magazines all available here, and of course, as I mentioned before, a podcast. Now, to show you just how simple it is to order from Rupa Health, I'm going to show you just that. All you need to start an order on Rupa Health is your patient's first name, last name, and email address. Rupa Health is a free account to sign up for. There's no contract. There's no monthly fee. There's no subscription, none of that. It's a free platform to sign up for. And once you're inside of it, you're able to start an order. You can create custom bundles, which are sets of tests, sets of blood panels, a combination of tests from any one of the labs that we work with. Down below, you can create a favorites list. So individual tests that you're commonly ordering, you put a heart next to it. And so if I want to order that testosterone test from ZRT, or maybe a hormone trio from ZRT, click. And if that's it, I just click send a patient. And that's how simple it is to order from over 30 different labs, of course, including ZRT, and quite literally a matter of seconds. If there's any other test that you want to maybe add on to this, right? Maybe you want to add a gut test onto this as well, right? So you're treating the hormones as well as maybe the gut and the GI. You can add those on there from any different lab that we work with, instead of having to have separate accounts to log into to order your tests, instead of having to go to each individual lab to order and manage your results. It's all here in one place. Additionally, we offer wholesale practitioner pricing. So what that means is the same price that you would get having an account directly with the lab. That is the same price that we offer here at Rupa Health. So it's the same cost. The way that we generate our revenue is there's a flat 7% processing ordering fee on each order. So as you can see, the cost to use Rupa in this circumstance is $7. Pretty small, pretty nominal, right? And that's paid for by whoever's paying for the test. So what I mean by that is we have two options. You can either have us manage billing directly with your patients, or you can pay for the test yourself and manage billing separately. Either way, the cost is the exact same. However, the benefit having us manage billing with the patient is, in that case, the patient will pay that 7%, and there Rupa is free for you. That 7% is how we generate our revenue. And so as long as you're having us manage billing directly with the patient for each order, you'll never pay a dime to Rupa Health, of course, unless you want to. Once you press send on that order, we will reach out to your patients. We'll drop ship the kits to them. We'll send over instructions and FAQs, walking through how to take the test. We'll answer any support questions. So a really important component to Rupa Health is we will handle that patient experience for you. The goal here is to offload that necessary admin work, the support that takes a lot of your time, to be able to focus on what truly matters, and that is seeing more patients, helping more patients achieve their goals to health and wellness. And we will offload all that heavy lifting off of your shoulders onto ours for that simple cost of 7%. Again, Rupa Health, free to sign up for. If you do have any questions, feel free to reach out directly to me. My name is Adrian Martinez. I'm the head of practitioner partnerships here at Rupa Health. I'm going to go ahead and put my contact information on here as well. So again, you'll know how to reach out to me. And there we go. A couple of really just important details about Rupa, right? It's free to sign up for. Right now, we only operate within the United States. So unfortunately, if you are abroad, we can't work with you directly. However, if you do have patients in the US, we'll likely be able to service them. Additionally, beyond that, Rupa operates on your license type, right? And so if your license allows you to order directly from the labs, then you'll be able to order from Rupa Health. However, if your license does limit the access that you have to certain labs or tests, then we do have a program. It's called Physician Services. You're able to enroll in that. And what will that do is that will allow you to partner with a licensed physician who will be able to order the tests that you're interested in for your patients on your behalf. So it opens up the entire scope of ordering for you in your practice. Additionally, beyond that, you can have multiple people on an account. I was speaking with a clinic earlier who had multiple practitioners, multiple admins, multiple nurses. We can work with you independent of whether you're a solo practitioner in a small clinic or a large multi-practitioner, multi-location clinic. We can set up your account to work and streamline however you want us to operate for you. Additionally, beyond that, Rupa is intended to streamline your business. If there are still other tests that you prefer to work directly with for whatever your business is, right, that's completely fine. And you only want to use Rupa for certain circumstances. Rupa is a free tool, right? And so really kind of keep that in mind, is that we want to ensure that we're supplementing and enhancing your business. If it ends up being 100% of your business that you use on Rupa, that's fine. If you want to do certain tests on Rupa and maybe you have a different operations for other, that's fine too, right? The beauty of having a free test, a free account on Rupa Health is that. Let's see, I'm going to hop in and see if there's any questions for me that came in. Doesn't look like there was, but again, my name is Adrian Martinez. Huge shout out to ZRT, Dr. Smith. We love them as partners. Be sure to order those tests on Rupa Health. And also, I'm going to send out the details on how a great number of you are probably going to receive a copy of Dr. Smith's book. So big shout out to ZRT and Dr. Smith on that. If you have any questions, don't hesitate to reach out. Again, my name is Adrian Martinez with Rupa Health. We do these basically every week with some amazing lab partners. So I hopefully will see you there. And if you have any questions, don't hesitate to reach out. Enjoy the rest of your day. Thanks, everyone.